Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of MRCP within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam, or indeed medical advice. Please refer to your college of entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is the second question series on catching your breath, and this one's all about restrictive lung disorders, infections and miscellaneous conditions. So now for a question. A 50-year-old farmer presents to the acute medical take with 48 hours difficulty breathing, associated with wheeze. On examination, he is found to have bibasal crackles. A chest X-ray is performed which reveals diffuse interstitial shadowing. A case of EAA is suspected. Which of the following antigens is most likely the responsible agent? So our options are Micropolyspora pheni, avian proteins, Aspergillus clavatus, Penicillium casei, and Thermoactinomyces saccharoi. So you'll remember that all of these may potentially lead to EAA depending on one's occupation, but the most pertinent one, given that this particular individual is a farmer, would be Micropolyspora pheni. So now time for some questions. The first question is, a 60-year-old man with a 20-pack-year history of smoking presents to the acute medical take with a 3-month history of unintentional weight loss of 2 stone and fatigue. His serum sodium is 127. Given the likely diagnosis, what is the next most appropriate investigation? So our options here are sputum sample and culture, PET CT scan, endobronchial ultrasound or EBUS, high-resolution CT scan or HRCT, or a chest X-ray. So in this case, the correct answer is a chest X-ray, just given those symptoms that the patient has presented with, and is the most easiest and efficient form of imaging to get in the acute setting. Question 2. An 85-year-old lady presents to the ambulatory care unit with a 4-week history of confusion. On examination, the IMT1 doctor notes bilateral digital clubbing, as well as a non-tender 4 cm supraclavicular lymph node with associated unilateral ptosis. Her serum adjusted calcium level is 3. Given the likely diagnosis, what is the most likely subtype of malignancy? So this requires you to think back upon the paraneoplastic syndromes that can be associated with the various forms of lung cancers. So our options here are small cell, large cell, squamous cell, adenocarcinoma, carcinoid. The correct answer here, which you may recall, is squamous cell, and it is important to try and remember which forms of paraneoplastic syndromes are associated with which types of lung carcinoma, as this can be quite a common question in the MCQ exams.
Let's do some questions. Which of the following is incorrect? All patients with the diagnosis of mesothelioma are entitled to government compensatory schemes. B. Mesothelioma is particularly high risk for seeding, therefore drain sites should be irradiated. C. Median survival of someone with mesothelioma is 1 year. D. Pleurodesis can be done as soon as diagnosis is suspected. E. Recurrent pleural aspirations can be considered for symptomatic management of patients with mesothelioma. So if you recall from our discussions earlier, you will hopefully remember that options A and option C are correct. You must inform all the patients with a confirmed diagnosis of mesothelioma that they would be entitled to government compensatory schemes. And unfortunately, the median survival is very poor, of about 1 year. Given the fact that this is a really dangerous disease, it's also really important to be thinking about management of patients when you're putting chest drains in them. And mesothelioma are particularly notorious for seeding. So if you decide to have a chest drain in a patient, it would be important to make sure that the drain site is irradiated to avoid the cells to seed. With regards to option E, it's also quite logical. not just in the context of mesothelioma, but any other condition such as lung cancer that leads to recurrent pleural effusion, it's not too uncommon to see patients coming to hospital or respiratory outpatient clinics to have their pleural effusion drained. So therefore, option D is the incorrect option, which if you remember, you will know that pleurodesis must only be done once the diagnosis is confirmed on tissue, and it should never be done on somebody who's just having a query of mesothelioma. So let's do some questions. A 60-year-old man presents to the acute medical take with a history of unintentional weight loss of 2 stone and hemoptysis. On examination, the IMT1 doctor notes cervical lymphadenopathy and right-sided reduced chest expansion and breath sounds, with associated dullness to percussion. The respiratory registrar on call performs an ultrasound-guided pleural aspiration. Given the likely diagnosis, which of the following statement is incorrect? A CT tap is indicated. B, cigarette smoking is the biggest risk factor for this condition. C, increased vocal phreatus will be expected on examination. D, the pleural effusion will be consistent with an exudate. E, a pH of less than 7.2 could indicate a complicated empyema. So to answer this question, let's just revisit the vignette again. So you have a middle-aged gentleman who's presenting with unintentional weight loss and hemoptysis. And hopefully that is enough for most of you to appreciate that the big thing that you need to be worried about in this case is either A, cancer or infection. It then goes on to tell you that the IMT1 doctor has picked up cervical lymphadenopathy and signs and symptoms that is consistent with the pleural effusion. And in fact, it tells you that this is a pleural effusion because later on it tells you that the on-call respiratory registrar has performed an aspiration on the case. So this is hopefully, given the fact that there also isn't a mention of any hemodynamic instability, suspecting of sepsis or raised infection markers, or for instance, pyrexia, hopefully this is all leading you towards cancer. And looking at your choices, option A is saying that a CT tap is indicated. That sounds reasonable because if you're suspecting a cancer, you would want to be thinking about what's the extent of this disease and how far has it spread, because obviously that is going to change the management that you would be offering to the patient. Option B is saying that cigarette smoking is the biggest risk factor for this condition, which is also true because smoking remains the biggest risk factor to develop lung cancer. Option D, it tells you that the pleural effusion will be consistent with an exudate. Well, that's correct, whether that's an infection or cancer. Option E is saying that a pH of less than 7.2 can indicate a complicated empyema, and that is also correct. If you have a pH of less than 7.2, that suggests a very acidic effusion, and that the first concern would be that this could be an empyema, which would be an indication for drainage. So the only thing that is going to be left that will be the incorrect option here, which would be the correct answer, is option C, which is saying that you would expect increased vocal phreatus on examination. That is incorrect because your vocal phreatus will be reduced in the case of a pleural effusion.
A 65-year-old man with a BMI of 35 presents to the respiratory outpatient clinic with a 3-month history of fatigue and somnolence. His partner also mentions he is snoring through the night. Given the likely diagnosis, which of the following statements is incorrect? So our choices are: he must inform the DVLA about his condition, Epworth Sleep Scale is indicated, polysomnography is the gold standard test of choice, he might require treatment with BiPAP, he should be assessed for other risk factors of metabolic syndrome. So the incorrect answer here is D, because he does not require treatment with BiPAP. It is in fact CPAP that is used for OSA, which is the likely diagnosis in this case. If you would like more information about OSA, then please check out our previous YouTube video on obstructive sleep apnea, which can be found here.
A 65-year-old lady with a history of osteoporosis and COPD presents to the medical take with a 3-day history of worsening shortness of breath, accompanied by productive cough of green sputum. On examination, she is noted to have severe kyphoscoliosis from previous spinal fractures and an expiratory wheeze throughout her chest. Which of the following arterial blood gas reading is most consistent with this presentation? So I'll give you guys a minute to read all of these, but having a look at these, option A is pH of 7.5, PCO2 of 8, PO2 of 10, bicarbonate of 22. Option B is a pH of 7.5, PCO2 of 8, PO2 of 7.8, and bicarbonate of 22. Option C is a pH of 7.31, PCO2 of 8, PO2 of 7.8, and bicarbonate of 22. And option D is a pH of 7.1, PCO2 of 8, PO2 of 12, bicarbonate of 22. And option E is a pH of 7.5, PCO2 of 6, PO2 of 11, and bicarbonate of 19. So looking at the history, hopefully you will remember that having severe kyphoscoliosis is one of the causes for type 2 respiratory failure, in which you have problem with both getting the oxygen in and also excreting carbon dioxide. And looking at the vignette, it sounds like this patient is also presenting with an element of decompensation resulting to expiratory wheeze throughout, as well as having productive cough of green sputum. So you should be suspecting a bacterial or viral infection that has basically exacerbated her COPD. So just by that information, those of you who work on medicine should know that the type of gas that you would be expecting for this patient would be a decompensated type 2 respiratory failure, in which you will have a low PO2, a raised PCO2, and very frequently patients are in acidosis. So by definition, option A, B, and option E are incorrect because they're not in acidosis. So really you're dealing with either option C or option D. And looking at these, C is the correct option because you have raised PCO2, you have low PO2, and you have acidosis. Option D is incorrect because your PO2 is pretty much normal, and that is the sign that this gas has been taken on somebody with potential of this history with COPD, but they are over-oxygenated.
So let's try a question. A 70-year-old man with a background of type 1 diabetes presents to the medical take with a 4-day history of being generally unwell, with shortness of breath and pyrexia. On examination, the IMT1 notes bilateral crackles at the base of his chest, with an oxygen saturation of 65% on room air. He is started on high-flow oxygen and up-titrated as per his oxygen sats. A chest X-ray reveals diffuse bilateral patchy consolidative changes, with no evidence of cardiomegaly. He is suspected to have ARDS and is referred to the intensive care unit. Which of the following statements is incorrect? So our options are A, an echocardiogram is indicated, B, he should be worked up for potential sepsis, C, COVID and flu swabs are indicated, D, a high-resolution CT chest is the first-line investigation of choice, and E, he should be considered for CPAP. So the correct answer here is D. You would not be considering a high-resolution CT chest scan as the first line. This would be done further down the line once the patient has had an established diagnosis and the immediate emergency treatment has been instigated. So let's try a question. A 65-year-old lady with a background of breast cancer treated with chemotherapy and radiotherapy presents to the acute medical take with a 10-day history of being generally unwell with flu-like symptoms. An arterial blood gas shows type 1 respiratory failure. A chest X-ray shows bilateral patchy consolidative changes at the bases. She is suspected to have cryptogenic organising pneumonia on the respiratory post-take ward round. Given the condition, which of the following is incorrect? So our options are A, treatment with steroids is indicated. Option B, HRCT will show ground glass appearance. C, HRCT will show a mosaic pattern. D, the prognosis is excellent. And E, a VATS is indicated. So the correct answer here is HRCT will show a mosaic pattern, as we would expect the HRCT to show a ground glass appearance. It's also, of course, important to remember in this case that the vignette is giving you the answer for the diagnosis of cryptogenic organising pneumonia. So this assumes that within the vignette, adequate tests have been carried out in order to exclude other diagnosis, because, of course, in real life, this patient would be at very high risk, for example, of chest sepsis, but we've been given the diagnosis in this case, so we're basing the answer on what we have been told the diagnosis is, which is cryptogenic organising pneumonia. So if we now do a question, an 18-year-old male smoker presents to the emergency department with a 2-hour history of sudden onset breathlessness associated with pleuritic chest pain whilst running. His chest x-ray on arrival shows a 1.8 centimetre right-sided apical pneumothorax. He is referred to the medical registrar for management. Which of the following statements is correct? So our options are needle aspiration is not indicated, chest drain is the first line of management, given his pneumothorax is less than 2 centimetres, he can be managed conservatively. This is a case of a secondary pneumothorax, and he should be referred for smoking cessation therapy. So in this case, the correct answer is the last one, E. He should be referred for smoking cessation therapy, as this does increase his risk of having pneumothoraces, as well as, of course, other health problems. The reason, if we go through the others, why they are not correct, so needle aspiration is not indicated. This is incorrect because he is symptomatic. However, chest drain is not the first line of management, so this rules out option B. Option C says he can be managed conservatively, and this is not true again because he's symptomatic, so he will need aspiration. And D says this is a case of secondary pneumothorax, but again, this is not true. He does not have any known underlying lung conditions. And the fact he's a smoker does not count in terms of calling this a secondary pneumothorax, as he is under the age of 50, if you refer back to the previous slide with the schematic. So now let's try a question. A 30-year-old lady who is 6 days postpartum presents to the acute medical take with worsening shortness of breath and pleuritic chest pain. She is breastfeeding her newborn child. She is suspected to have a pulmonary embolism and subsequently has a CTPA which confirms the diagnosis. Which of the following statements is correct? So our options are she can be treated with a DOAC, treatment dose low molecular weight heparin is the most appropriate treatment for her, warfarin is a safe option by which to treat her, a thrombophilia screen is indicated, she can be ambulated if her blood pressure is stable. So the correct answer in this case is option B, which is that treatment dose low molecular weight heparin is the most appropriate treatment for her. It's important to remember in this case that she is postpartum and she is breastfeeding, and therefore automatically we cannot give her a DOAC or warfarin. A thrombophilia screen is not indicated here in this case because she has a confirmed risk factor. She has recently been pregnant, and it would be unsafe to ambulate her at this time, even if her blood pressure is stable, as she does have other risk factors. Thank you for listening to this episode of Bite-Sized MRCP. If you like what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss our next episode. Let us know in the comments which topics you would like to hear in future. See you in our next episode.